Thank you. Thank you for having me this evening. I'm going to get right into it. I've been tasked to sort of talk to you about the transition from what we just heard from the science aspect to taking care of patients and how it works. And just to get going, I'm an interventional cardiologist. When I explain what I do to patients, I tell them I'm a plumber and I'm going to open their arteries. So it was interesting to try and figure out how am I going to explain the autonomic nervous system to lay people. And I think going back to things we saw in med school and a picture's worth 1,000 words. And so it's a lot easier to make it understandable for someone to grasp the complexity of what we just heard in the prior two lectures by showing them a picture and knowing that they probably remember experiences in their life when they probably had parasympathetic activation versus sympathetic. So I use this homeostasis and talk about how congestive heart failure in general is an imbalance of the seesaw toward the sympathetic side, and that this device is going to do something to change that balance. From another standpoint in terms of what it looks like, there's a carotid sinus lead. A small incision is created to access the carotid bifurcation and secure the 2-millimeter electrode and lead. There's an implantable pulse generator that is then tunneled. The lead is tunneled over the collarbone and connected to the IPG in a standard device pocket, very similar to a pacemaker or ICD generator. This is typically implanted in about an hour, the procedure takes, and many places are doing this procedure as an outpatient in either the OR or in a hybrid OR. And this just takes you through the steps that I just described, very similar to the slide prior. Small incision, electrode sutured, tunnel the lead, connect it to the device, place it in the pocket, and then you end up with 2 incisions. And in terms of what would be required clinically, so in follow-up, there should be a post-op follow-up from a surgical standpoint, and then the first follow-up is in approximately 2 to 3 weeks post-implant, and essentially the first 3 to 6 months are spent bringing the patient back at different intervals depending on how they're doing to up titrate the device. And after about 6 months, if things remain pretty stable, from a device standpoint, it would potentially be only 2 times per year. The average battery life is 5 years without any charging required. And so patients to consider, I mean, this has been reviewed in the first lecture and again with the BEAT-HF trial, but the indications currently are New York Heart Association Functional Class 3 or Class 2 with a recent history of Class 3, an ejection fraction less than or equal to 35%, NT-proBNP levels less than 1600, and it is not indicated for CRT or for those not receiving adequate response from existing CRT device. So the patients that I consider, so patients who have an ICD and they're still symptomatic despite goal-directed medical therapy, CRT non-responders, hospitalized for CHF or recurrent hospitalizations, patients with high-risk indicators such as syncope, ventricular arrhythmias, CVA because of potential LV thrombus because of severely decreased EF, but mostly decreased quality of life. And when you see these patients over and over, you hear them saying, I can't shower, I can't make my bed, I'm tired cooking, stairs are frequently out of the question, I can't walk a few blocks anymore. I get this all the time. I was very short of breath walking into your office today from the parking lot across the street, shopping, spending time with their younger family members, children or grandchildren. And then the things that they used to do seem to be something of the past, golfing, gardening, traveling, etc. So with that, I'm going to get into 3 case studies of my patients and their course. So this was a 74-year-old man who had a 20-year course of ischemic cardiomyopathy. So before I met him, he had CAD defined as some sort of MI in 2001, of which he did not know the details. Later, another acute coronary syndrome with an RCA PCI, obviously diagnosed with an ischemic cardiomyopathy with an EF of 35%. And before I met him, a BIV ICD was placed in 2012. He also had paroxysmal AFib, hypertension, hyperlipidemia, diabetes, chronic kidney disease. And in 2013, one of my partners met him with New York Heart Association functional class 3. And in those years, he had, at that time, he had 9 congestive heart failure admissions over 15 months, including 4 thoracenteses. And in 2014, someone said he should have another angiogram. And lo and behold, an LAD CTO was found. A viability study was performed. There was viability. He eventually had a single vessel CABG, Lima to LAD, and his post-op EF was about 40%, and he improved. He became functional class 1 to 2, and that was in 2014. Fast forward to 2019, when he became my patient, he was functional class 3 with an EF of 30% and an LV thrombus when he represented. And over the course of 19 months, he had 6 heart failure admissions, 8 thoracenteses, and by June of 2020, his EF had dropped to 20%. A few months later, he had a syncope admission. He was hypotensive. He hit his head. Thankfully, his head CT was negative. Again, his EF was still 20%. So going through the usual algorithm, he did have another cath. His Lima to LAD was patent. His RCA stents were patent. He had moderate circumflex and right PDA disease, both of which were evaluated with FFR and found to be negative. And his LV EDP was 12. He was on amiodarone, Coreg, only 3.125 BID, digoxin, Lasix, 40 BID, potassium, synthroid, spironolactone, metolazone, simvastatin, Coumadin, and Plavix. And so we talked to him about this procedure, this device, and he agreed to it, and it was implanted in October of 2021. And so in follow-up 2 weeks post-implant, he came to the office. He reported decreased shortness of breath. He said he felt improved, and he had not used any metolazone since the implant. 2 months post-implant, he still was reporting less and less shortness of breath. And now he actually said for the first time, and his family could definitely notice that he had improved energy. He was now using Lasix just once a day instead of BID, and he had had no recurrent CHF admissions. And 9 months post-implant, that's where we are now. He has not been readmitted at all. He's using Lasix only PRN, and he's New York Heart Association functional class 1 to 2. So this is after 20 years of dealing with his ischemic cardiomyopathy and, all in all, 15 heart failure admissions. Moving on to the next study, or the next case study. This is a 79-year-old woman with a non-ischemic cardiomyopathy. So she was initially diagnosed in 2014. Her EF was 40%. She had a known left bundle branch block. At the time, her NYHA class was 2, and she was having frequent PVCs, but was on some degree of medical therapy and really didn't have that many complaints. Fast forward 4 years, she presented and reported decreased exercise capacity, saying she used to be able to walk 1 mile a day and now was walking 2 blocks over the prior year. She was found to have paroxysmal AFib with also a different arrhythmia of ATAC, pre-syncope, and a CRTP was placed at that time. A year later, her EF was 30%, and she was having salvos of non-sustained VT, and her CRTP was changed over to include an ICD. In November, a few months later, she had syncope with her ATAC, and she had been intolerant to numerous antiarrhythmic medications that had been tried, including propafenone, amiodarone, Ticozin, actually caused VT. So she eventually went an A-flutter ablation. They did find her ATAC, but they said it was too near the sinus node and it was not ablated. At the time, she had tried Entresto, but developed a cough. She also had on-off kidney failure, also developed a cough with hydralazine. The following year, her EF was still 35%, but now she was class 3. She was offered an AV node ablation due to ongoing tachyarrhythmias and medication intolerance. She had this done, and in July, she had no improvement and actually had several episodes of ventricular tachycardia and ventricular fibrillation with her device. She was admitted, she was hypotensive, also had hypokalemia at times and hyperkalemia. She was short of breath and her EF was 20 to 25%. At the time, she was on Coreg, spironolactone, Lasix, and Eliquis. And we recommended a Barostim to her, but she had been through so much that she decided she was going to think about it and put it off. So she finally came last November and had it implanted. 1 week post, she came to the office and said she felt like she was significantly improved from a shortness of breath standpoint and was only using Lasix PRN. 2 months later, she said she felt great and that her last episode of shortness of breath had been just prior to the implant and that she had improved energy. 4 months later, she had had no recurrent admissions and she was New York Heart Association class 1 to 2. And 4.5 months later, she had a repeat echo and her EF had improved to 40 to 45% and was doing well. Now we're at 8 months post and she has not been readmitted and is doing well. And just one last quick case. This is another woman, 77 years old, non-ischemic cardiomyopathy, horrible EF of 10 to 15%, New York Heart Association functional class 3, had had a CRTD placed in 2016, hypertension, hyperlipidemia, CVA, history of breast cancer, right mastectomy, depression, some mild dementia, and actually an LV thrombus. And she had had multiple CHF admissions over 5 years at different hospitals and had been intolerant to several different medications and max doses, including episodes of hypotension and on and off chronic kidney failure. Her meds now included Corlinor 7.5 BID and Entresto low dose, Lasix 40 BID, Eliquis, and Zoloft. And she had a Barostim implanted last July, actually a year ago. 2 weeks post-implant, she had decreased shortness of breath and significant decrease in her edema. 2 months later, her EF was about 20 to 25% and no longer had an LV thrombus. And right now we're at 4 months later. Sadly, she's had 4 congestive heart failure admissions, but they are all secondary to patient noncompliance. Her dementia has progressed, and what has happened is the family reports she starts feeling so well and being very active, and she thinks she's cured, and she stops taking her medication. So the Barostim alone isn't enough for her. She's got to stay on her meds, but this has resulted in 4 CHF admissions. But once she's on her meds, she does quite well. So in summary, the Barostim, as you heard earlier, is FDA approved for improvement of symptoms in patients with heart failure with reduced ejection fraction. It's a novel device option for patients who are not indicated for CRT or who are refractory to goal-directed medical therapy and or CRT. In the BEAT-HF study, the Barostim significantly improved quality of life, exercise capacity, functional status, and NT-proBNP.